Today we're going to talk about nutrition assessment of a pediatric patient. For those of you who've been with me through medical nutrition therapy and chronic care and acute care, you've learned a lot already about how to assess the adult patient, but today we're going to learn a little bit about how pediatric patients are just a bit different. Today we're going to talk about some ways of identifying nutrition risk in children. So just as there are ways of using screening tools to assess risk in adults, there's some slightly different ways to assess risk in children. We'll talk about differences in nutrition assessment in children compared to adults. We'll talk about methods that we use to measure children and how to use those methods accurately to get the best possible measurements. We'll go on to talk about interpreting growth and then how to estimate energy and protein needs. And finally, we'll talk about some aspects of poor growth, malnutrition, kwashiorkor versus marasmus, acute versus chronic malnutrition, and then we'll talk a little bit about ages and stages. So to start with, I assigned you an article by White and al. To read. It was in the Journal of Parenteral and Enteral Nutrition a few years ago, where they compared a screening tool that asked some questions that could be easily administered by a nurse when a patient was admitted to the hospital, or even maybe by a physician or a physician assistant in a clinic to identify nutrition risk. And they compared it to using Pediatric SGA or some other processes, and found that these 4 questions combined, that if a child had scored positively on at least 2 of these questions, that it was fairly sensitive and specific for identifying risk for malnutrition. So the questions were, has the child unintentionally lost weight lately? So that's similar to adults. Has the child had poor weight gain over the last few months? And so this should be a reminder that in children, we expect not just that they'll have stable weight, but that if they're growing, they should continue to have slow weight gain over time. Also, has the child been eating or feeding less in the last few weeks? And then is the child obviously underweight or significantly overweight? So those are some of the key sensitive questions for identifying nutrition risk in children. At Children's Health in Dallas, where you go in the spring for your practical experience, the nursing screen includes the following triggers: unintentional weight loss within the last month, and feeding problems interfering with intake. So 2 of those are actually present in the article by White, unintentional weight loss and feeding. But then they also have other screening triggers, including special dietary education needs, if the child's already on TPN or enteral nutrition at home, if they failed to gain weight in the past month and they're less than 1 year old. So that goes to number 2 on that screening tool, although this one includes just young children, whereas the other screening tool includes all. Also, if the patient or the parent requests nutrition, if there's concern regarding breastfeeding or concerns about milk supply. And then at Children's, the diet techs actually go back through, either the diet tech or dietitian, and they re-screen every patient's chart to make sure that nothing was overlooked in the nursing screening. And so they're looking at growth parameters, at the diagnosis, if the diet and formula order, if it's maybe something that's concentrated or specialty, how many days they've been in PO, if they've been missing meals, like if the diet tech notices they've not been eating, if they're on nutrition support, if they have a nutrition or lactation consult, and also if they have drug-nutrient interactions. So as the little picture on the slide shows you, this is kind of their second way of catching anybody who fell through the cracks on the initial screen. Now, the first thing we need to talk about if we're going to talk about pediatrics is how do you figure out how old they are? In general, if you're at Children's Health, you're not going to have to do this. It will be pre-calculated for you and you won't have to bother. And there are probably many places where this is the case, but it's still important for you to be able to hand calculate a child's chronological age if you need to. And to that, you first set up the problem. As can be seen here, you always organize it so it goes year, month, day, always in that order. And you always take your current date and subtract the birth date from it. And you always subtract from right, beginning at day, to left, year. So on the next page, we have a couple of the rules, and you can see how these are applied. So if the number of days, like here, let's see, the child was born on, it's July 16th, or the current date, let's say, is August 16th, sorry. For the days here, 16. And the number of days is less than the birth days, which here it's the 26th. You subtract 1 from the current month, so you take away 1 month, and you add 30 days, because 1 month is equivalent to about 30 days. So we cross out the August, make this 7 months, July. We add 30 days here to make this 46, and then we can subtract 26 from 46, and we get 20 days old. Now coming here, there's 0 months, and subtracting 2007 from 2016, this is a 9-year-old who's 9 years and 20 days old. Another rule is if the test months is less than the birth month, see here it was test month was 1 month, birth date was 3 months, then you subtract 1 from the current year, and because there are 12 months in a year, you add it to the months and then subtract. So the 27th minus the 26th is 1 day. Adding 12 to 1, you get 13 minus 3 is 10 months. And then 2015 from 2005, it's a 10-year-old who's 10 months and 1 day. Now, there's also the principle of rounding. So if on those, going back, you get 0 to 15 days, like here, you're going to round to 0 months. You're not going to add a month. But as in here, you get 20 days, well, 16 to 31, you're going to round up 1 month. Okay? So in this case, you would actually say they were 10 years and 10 months, but in this case, they're 9 years, and you would round to 1 month. If we're rounding months, if they're between 0 and 1 month, you round to 0, 2 to 4, a quarter, 5 to 7.5, and so on. Okay, when we're talking about age with children, we also have to consider more than just chronological age. So going back to your growth and development, you may remember the child was considered to be term if they were born at least 38 weeks, 37 completed weeks. And so in that case, a term infant, you don't have to do any particular correction, right? They can plot on the 0 line on the WHO birth to 2-month chart beginning when they're born. But for children who are born preterm, we often correct their age. And so we do that because, for one, we want to better determine the most age-appropriate feeding method or developmentally appropriate feeding method for the infant. We also want to appropriately assess their growth. If they were very preterm, we don't necessarily want to compare them to infants who are born full term. And so we calculate that corrected age and use it until they're at least 3 years of age. And so to correct, you first determine how preterm the infant was at birth in months, then you subtract that from the current age, and it gives you the corrected age. So an example is the preterm infant born at 30 weeks gestation, their current age, 3 months. And so we go back, and if we say that if 40 weeks is term minus 30 weeks, they were 10 weeks preterm, we want to convert that to months, so we divide by 4 weeks in a month. We say they're 2.5 months preterm, and so their current age of 3 months minus 2.5 months means they're about a half a month or 2 weeks corrected age. And so you could plot this infant at 3, if you wanted to figure out if they were growing well, you could both plot them at the 3-month line, their chronological age on the WHO chart, to see how they are looking compared to term infants, but then you could also plot them at a half a month to see how they're doing for their corrected age. And ideally, over time, you want to see them as they move from birth to 24 months, actually moving up on the chart and kind of moving into more normal territory. There's also this concept of postmenstrual age or corrected gestational age. And that's a little bit different than a regular corrected age. This is used for an infant who is preterm, and often it's used on an infant that's been hospitalized since birth, or who is still, even, let's say they've been discharged from the hospital, they're still like, if they were born at 24 weeks and they've been discharged at 32, well, they're still less than 0 months corrected age. And so you use the specialty Fenton growth chart to plot them, and you would need to correct their gestational age in weeks. And so to do that, you basically add the current age in weeks to the preterm age that they were born in weeks. So for example, if the infant's currently 4 weeks old and they were born at 26 weeks, well then their postmenstrual age or corrected gestational age is 30 weeks. Okay, so we know the pediatric assessment is going to be very similar to adults in that we use the ABCDPs, the Anthropometrics, biochemicals, client history, dietary assessment, and the physical exam. But we also have to consider these other factors that are important to pediatric nutrition. One, we have to figure out their age and whether it needs to be corrected or not. Two, we don't uniformly use height. We use height if they are able to stand and they're more than 2 years of age. And we use length, recumbent length, if they're less than 2 years. We track their fronto-occipital circumference or their head circumference if they're less than 3 years of age. And then we also look at their birth weight and length of gestation if they were less than 3. So if they're an 8-year-old, you're not going to go back and look at how small they were when they were born or how many weeks gestation are. But if they're less than 3, you're going to use that and correct. And then the other thing that's really key here is growth velocity. This is something we obviously don't track with adults because adults don't grow, but it's important to calculate how quickly infants are growing or toddlers or school-age children and compare that to accepted standards to see if they're really tracking the way they should be. Another way of doing that outside of calculation is just to follow a growth curve over time to see if the child maintains more or less the same growth track. And you did this quite a bit in growth and development. So this will be a review. In terms of how we measure, remember for weight, we use the regular beam balance scales or digital. For length, you should use a length board. There's some length mats and other things that you can use, but it's important that the child be lined up correctly with their head up against the top of the board, their feet flat against the base, not pushed down. Oftentimes, if you can just get 1 foot straight and the baby lined up, you're doing well. With the height, you want to make sure their heels, buttocks, shoulders, and head touch the measuring surface and they're looking straight ahead. And then, of course, when we're looking at indicators of adiposity, you're going to look at weight for length, which is seen on the WHO chart if they're less than 2 years, and then you're going to track their BMI if they're on the CDC chart, the 2 to 20 if they're more than 2 years. An arm span you may use in children with special needs. So if you had a child with, let's say, for example, cerebral palsy who is unable to stand, but who didn't have many contractures and could fully extend their arm, then you could look at the distance from their fingertip to fingertip, their middle fingers, or if you couldn't do that, you could go from the center of their spine to 1 middle finger and then double that. Also going back to adults, you can use triceps skin folds using a Lang standard caliper and taking 3 measures and using the mean. And you could use that combined with the mid-arm upper arm circumference to kind of look at measures of adiposity and muscle mass. And this is just another table that reminds you of how to correctly measure growth. And this is a picture of it. You'll see in this that it's really better to have 2 people doing the measurement of the child. And really this child's chin is tucked down a little bit. They should probably be a little bit more up, and this doesn't look like a fully straight leg. But always having 2 people is easier than doing 1. And also, if you see this diaper here, you always want to make sure that the diaper is clean and dry so that you're not adding significant weight. Because if you have a diaper especially that's full of urine, it's going to be way much heavier And so you may see a difference in weight from visit to visit that's really not attributable to actual weight. It's just a heavy diaper. Just reminders, we talked about this as we went, but the Fenton growth chart is the one you'll use in the hospital for a preterm infant or for one who is less than about 0 to 1 month corrected age if they're outside of the hospital. And then the WHO if they're less than 2, the CDC if they're greater than 2 and able to stand, and you could use the CDC birth to 36 if they were 2 to 3 but not able to stand. I also want to remind you there are several disorders for which growth charts have been developed. The concern about these growth charts is that they were developed on very small populations who may have suboptimal growth. So, like specifically, it's no longer recommended that you use the Down syndrome chart at all. And some people in these areas really want to develop them and feel strongly about them, but you just really have to think about what it means if you're comparing them to other children with the same disorder, but if many of these children experience suboptimal growth. Do you want them to be close to the mean, or do you want them to come closer to the mean for a child who's typically developing? We talked about this quite a bit in growth and development, but just when you're interpreting growth charts, recognize that if height for age is very low, it can mean one of two things. It can mean simply that they have short stature because they have short parents, or it can be due to stunting. So long-term poor growth leads to low height for age. If they have low weight for age, well, then they can be said to be underweight, under expected weight. But their Z-score can tell you whether they have moderate or severe malnutrition. And then their BMI for age or weight for length can tell you if they actually are experiencing wasting, so kind of acute undernutrition and also malnutrition. And then overweight, we can really only do that using BMI. We don't have accepted standards using the weight for length charts. Okay. When you're looking to see if a child has acute versus chronic malnutrition, going back to growth and development, remember with acute malnutrition, usually you have an acute decrease in weight. And when I say decrease in weight, it may be that weight simply does not increase, but the growth plot changes, it moves downward. Because, for example, the child who weighs 10 pounds at 6 months, who still weighs 10 pounds at 8 months, has not lost weight, but their weight for age on the growth chart may have moved from the 50th down to below the 25th percentile, which means they've crossed at least one growth track. Acute malnutrition may have no change in length, or it may have a small change in length. They may grow in height a little bit, but not very much. And they'll generally have lower weight for length or lower BMI for age. Those who have chronic malnutrition, you'll find that weight and height have both height and weight will have decreased on the growth chart. And both may be below minimum standards, whereas the BMI actually may be lower normal. So it could be that it's decreased, like it's 10th percentile, 5th percentile. But it could be normal if this has been long-term malnutrition, and that just means stunting has occurred. You'll see this often in developed nations, but also in children who are just chronically in poverty-stricken homes where there's not enough food. Now, with all this discussion of weight and length, I want to remind you, going back to growth and development, that we also assess the newborn when they're born to see whether they grew normally in the uterus. So if they're appropriate for gestational age, it basically means they're between the 10th and the 90th percentile, weight for age and height for age. If they're small, that may mean that they have intrauterine growth retardation, and that means the newborn was less than 10th percentile weight for age. And if they're large, it means they're greater than the 90th. You can also classify them, rather than classifying them on the growth chart, just by their weight alone. So if they're low birth weight, that's less than 2,500 grams, very low, less than 1,500, and extremely low birth weight, less than 1,000. And then this goes back to that principle of growth velocity. There are actually some better, more precise charts that you can get through the World Health Organization, or you can also look at some software that I'll show you a little bit later. But this tells you that a 0 to 3 month old should be expected in terms of growth velocity to gain about 20 to 30 grams a day, and about a millimeter per day or per month, about 30 millimeters. Whereas the 3 to 6 month old has a slightly slower rate of weight gain, just 15 to 21, and a 6 to 10 month old about 10 to 13 grams. But especially if you see a child who falls outside of this growth velocity and they've been moving down on the growth chart, that suggests an abnormal pattern of growth. What is normal? Well, here you see a child who tends to follow one growth track. They're not small, they're 75th percentile weight for age, and they're around the 75th for height. And looking at the BMI though, let's see, they're kind of tracking up and down, got kind of close to the 85th here, and then moved down. And that could be due to a height that wasn't reported correctly. Maybe they measured shorter than they were, or maybe they were just increasing adiposity. They had that kind of adiposity rebound that occurs. But beyond looking at the growth chart, if you see a child who has a lack of height or weight gain, if they have a plateau or flattening in any one growth indicator for more than a month, if they have a drop in weight and then they don't regain it in a few weeks, like let's say they have an infection or an illness, but they don't regain that weight quickly, or if they cross growth curves, you want to find out if there's a good reason for what's going on, or if it's a nutritional problem. In terms of biochemical tests, I'm not going to go through these in detail. These are similar to what you'd see in an adult. But whereas for liver function is something you might see in an adult with suspected liver disease, you might want to look at those for those who are on enteral or parenteral nutrition, or those who are taking chemotherapy or other medication regimens. You actually do already look at lipids. The current recommendation is for screening at age 9 and 11, but especially you might look at triglycerides for those who are on parenteral lipids. If you're going to look at proteins like prealbumin and C-reactive protein, you're really not using those so much as nutrition indicators, but you might use those to follow whether a PICU patient, a pediatric ICU patient, was in the ebb or the flow phase of their critical illness. And then you might look at vitamin D for those at risk of deficiency. When you're getting a client history, the information which you would typically collect on admission at Children's is going to be, of course, the chronological age. You'll get the Anthropometrics and then how that causes clotting to occur. Also, the diet or formula order, the feeding route, whether that's breastfeeding, bottle, a toddler diet, a regular diet, diagnosis, the birth weight and length, the gestational age at birth, and any food allergies. And then they're also going to look in particular to try to find diagnoses that they consider to be of special nutritional significance. So if the diagnosis is failure to thrive or malnutrition, that's obviously a nutrition red flag. But also if they're overweight or obese, if they have an inborn error of metabolism, the more common ones being like, for example, PKU. And then, or if they have renal disease, and that could include, end-stage renal disease or CKD, but it could also include nephrotic syndrome or acute renal failure. Cystic fibrosis is going to be more common in the pediatric setting than in the adult. A gastrointestinal problem, new onset diabetes, or an eating disorder. In addition, you're going to want to get that social history just like you would for an adult, but some things that might apply in a pediatric setting would be, are there multiple households? Adults typically live in one household, but children might live with two parents or two parents and a grandparent. They might be in foster care. Also, you are not necessarily looking at the literacy of the patient, although you might be, but the literacy of the parents and what language they speak or read, and also what sort of mobility they have. And then as always, if they're on complementary medicine or special supplements or alternative therapies, and why. When we're evaluating diet in young children, we do that typical daily recall in adults, which we know is not best practice. It's not very accurate, but we often use it to kind of give us a baseline so that we know how to interact with parents. You just have to remember when you're looking at young children, if you really want to know what they're eating, like let's say for research purposes, a weighed food record is probably going to be the only good way to get that information. But if you just need to know things about how they're breast or bottle feeding, of course, you can ask the parents. If they're in the 4 to 11 age range, using that 24-hour multiple pass method with the parents reporting, if you're doing research, it's probably the best way to gather information about what they eat. But in the hospital, you could do a 24-hour recall with the parents, especially if they're newly admitted. For those of us who are 16 years or older, you may want to go more with the diet history, where you can ask more detailed questions about food preparation methods and eating out. But recall that up to half of children over-report their intake, but overweight and obese children, like adults, under-report their intake. There are also, this is just a little bit more on methods of assessing diet. I won't ask you much about this on an exam, but just recall that in a pediatric population, especially in young children, you may want to ask not just about what they're eating, but textures of foods that they accept, if they're more a drinker than an eater, whether they're breast or formula feeding, how much and how frequently they're taking a feeding, if there are any additives. If they're being fed formula, you'll want to actually ask, how do you mix that? If they can't tell you how they mix it, like whether from a powder and how many ounces of water and how many ounces of formula, then you really have to question whether A, they're feeding the child, or B, do they have any set method, or do they just pour a little in? And that can really impact a child. If they're failure to thrive, and it's simply because the parents have no idea how to make their formula or don't pay attention to it, you want to catch that. Also, if they have any either real or suspected food allergies or intolerances. In terms of nutrition-focused physical findings, this is something you can do even with children. But in particular, you might look at the head and eyes for signs of dehydration, such as sunken eyes or even severe malnutrition. If they have brittle hair or hair that's easily pluckable, if they're showing temporal wasting or any neurological changes, skin, looking for dry or scaly skin, which could show both dehydration or malnutrition. And then also, if you're doing nutrition-focused physical exam with a child, you always want to explain to the parent what you're doing and why. So you'd always want to wash your hands in the presence of the parent and then say, you know, I just want to take a look over at your child as we're talking. Is that okay with you? Just to make sure that their skin and hair and everything looks healthy and that they're growing the way they should. And most parents would be glad for you to do that. And with that, you can begin just by scanning the child overall to see if they're awake, are they alert, are they interactive, are they conscious, are they oriented, any body movements they have, whether, let's say, for example, if they're jerky or if they're very floppy. Either of those two things are kind of out of the norm and might indicate neurological problems, whether they make eye contact, whether they're able to communicate. Then you could observe hair to make sure it's an appropriate color, texture, quantity. If it looked to be thin, you could do a little bit of a pluckability test gently. You could look at the temporalis muscle at the eyes for orbital fat loss, and then observe the color of the conjunctiva and the sclera. You might look at their buccal fat pads, their cheeks, to see if they're full and round or if they're flat or even hollow. And then you might look at the lips for signs of hydration or any cracking or sores. You also might assess the oral mucosa for hydration. And then the teeth. This is, kind of an indicator of, are they being well cared for? Are their gums and teeth being cared for appropriately? And then you could look at the body for quadriceps, the mid-axillary line for the ribs, looking for fat wasting. And then in the population that is, less developed, you'll often look for the feet for signs of edema, which would be a sign of malnutrition. And then on to skin and nails. So once you've done all those components, so remember Anthropometrics, biochemical, client data, dietary data, and physical assessment, you can assemble a pediatric patient profile. In the adult patient, we had kind of set things that we put in there, but we've added a few for the pediatric patient. So in addition to the patient initials, age, sex, and race, you would also tell whether they were preterm or term, and if they were preterm, what their corrected age is. Obviously, their current findings and current problems in surgery, any findings from physical exam, any abnormal lab findings, current meds, how they plot, their growth velocity, and their home diet. Are they breastfed, formula-fed, toddler diet, oral, enteral, parenteral, and then any food allergies. The next step after we have all of these is actually going on to estimate energy and protein needs. And in here, I'm just going to talk to you about basic estimation of needs. So this is more the healthy child or infant, not the child who's critically ill or in TPN or EN. In this child with no particular disease state, you can use the EER equations for children 0 to 36 months, unless you're seeing a preterm infant. And so the blue book is the children's handbook, which we don't have yet, but which I will give you a link to on your Moodle page that you can use until they come in a few weeks. So there's going to be a new updated version. And then if they're overweight or obese, you can use the TEE equations, but otherwise you can use the EER equations. Now, Children's has actually gone a step further, and they've taken a child of an average weight, in this case, for the 0 to 35 month infant, and I told you what the average is using that. And you can see it's a little lower for girls than boys because their average weight is a little bit less. Or you can put it into an equation. And they've also done the same here. This is probably even a little less accurate because it takes the mean age. So for 3 to 5, that would be 4. And the mean weight and the mean height to get this average EER. But there are also equations that you can use for that. So remember, the estimation equations are always going to be a little more accurate than the quick method because the average EERs are based on children of mean age, weight, and height for the category. And then for protein, really if you look at the RDA, it doesn't give this breakdown. It just says 1.5 for the 0 to 6 months and 1.2 for the 7 to 12. But the protein in formula is somewhat less efficiently absorbed, so you might have a slightly higher protein need for the infant who's formula fed versus the child who's breastfed. But you can see that the highest protein need is when they're quite young and they're really accruing lean mass quite rapidly. And then for fluid needs, you're used to kind of the 1 calorie per mil in adults, or maybe in using like a 30 kcals per kilo for fluid for most, unless they're fluid restricted. But in children, we have this slightly different method, where if they're 1 to 10 kilos, we do 100 mils per kilo. So that means if you're 8.2 kilos, you get 820 mils. If they're 11 to 20 kilos, you take 1,000. So 100 times 10, 1,000 mils for the first 10. And then after that, 50 mils per kilo. So for a 15 kilo kid, that's basically 1,250 mils. And for a greater than 20, it's 1,500 for the first kilo, and then 20 mils per kilo after that. And you're especially going to look at this in tube-fed children to make sure whether or not you need supplemental water. Now, we've already talked about malnutrition quite a bit in your adult courses, but there's a couple of separate documents that have been issued by Aspen and the Academy to address malnutrition in children. And just a reminder that the majority of childhood deaths worldwide, not so much in the US, are actually attributable to malnutrition. Less in the US, where we see more deaths due to congenital disease or due to accidents or SIDS. But types of malnutrition, just like in adults, you can have illness related, and then you can have acute versus chronic illness related. And then you can have non-illness related, which means that which is behavioral, socioeconomic, or environmental. So maybe due to anorexia, or meaning low appetite, or iatrogenic feeding interruptions, maybe due to something in hospital, or due to intolerance. And then inflammation related, so altered utilization of nutrients and hypermetabolism. And then a reminder just that acute malnutrition is that existing less than 3 months, whereas chronic is more equal to or more than 3 months. When a child is malnourished, they lose lean body mass, they develop muscle weakness, and this can really lead to developmental delay because they're not able to gain the skills that they need in order to interact with their environment. It can even lead to intellectual delay because they can't interact with their environment. So the child who is malnourished is not just someone who loses body weight, but also one who typically loses intellectual gains. They may be more susceptible to infection, and so the child with malnutrition may die because of an infection rather than the malnutrition itself, but they probably would not have gotten the infection had their immune system not been dysfunctional because of their malnutrition. They may also experience poor wound healing if they're hospitalized, let's say with a surgical wound. They may have prolonged hospital stays, and they also may be stunted. So remember, the best way to assess for malnutrition is by having serial, meaning weights and heights over time, maybe a mid-upper arm circumference. If you can't get a good weight, maybe you're out in the field and you don't have a good scale. You're in a patient's home, but you can still get the MUAC and use charts for that. You could also look at head circumference, a very small head circumference. Occasionally it just means the baby has a small head, but it can also be sort of an indicator of height. So if the head circumference is low, it may mean that the child has some stunting or some longer term malnutrition. And then the other thing that's important is Z-scores. And so there's actually this software, which I've cited here, that you can download for free. And this will allow you to find the Z-scores for a child. And so here's a screenshot of that. You can see you can put in the current date, whether the child's male or female, their current weight, their current length. It'll calculate a BMI for you. You can put in their head circumference, their MUAC, their triceps, and then whether they were measured recumbent or standing, whether they're edematous or not, and it gives you a Z-score. So weight for length, you can see this child is 0.29, so they're just fine, they're in the green. Their weight for age is a 0.04, still in the green. Length for age, BMI for age, all of that looks good. But if you had a child who's at nutritional risk and you put these in, it would tell you what that Z-score is and what their level of risk was. The other thing we need to talk about here are forms of protein energy malnutrition. So remember marasmus and kwashiorkor, and as we discussed in growth and development, marasmus is more characterized by wasting, and albumin may be normal or low, and the liver's normal size, and they don't have edema, and this usually develops over weeks to months. Whereas kwashiorkor is acute protein energy malnutrition, but with the presence of infection. And so because of that, you have more inflammation, which means you have low transport proteins, you have edema, and you may have subcutaneous fat that actually masks the muscle wasting, or edema that masks muscle wasting. And often you find dermatitis and hair changes also. And then you can also have marasmic kwashiorkor. So that's a child who's actually low weight for height, but they have some of the symptoms of kwashiorkor, and this often occurs with acute stress, and there's a very high mortality for that. Just by way of review, it's important to not consider nutrition in a vacuum with a child. It's also important to remember how old they are, and whether they were preterm and kind of how they're doing for a child their age. So remember, if you're looking at a toddler or an infant from birth to 1 year, well, birth to 6 months, the average infant is going to double their birth weight by 6 months. So that means if you have a typical 7-pound baby, by 6 months, they're going to be about 14 pounds. And by 12 months, they're going to be 21 pounds. So, you know, an infant who has gotten to the age of a year and still weighs less than 20 pounds is probably on the underweight side. Toddlers gain less. They grow less quickly, but should still maintain their growth curves. And then preschoolers actually gain even less. So from 8 ounces, or half a pound per month, so that would be 6 pounds per year, to about 4.4 pounds. And then they're growing way less, 0.4, again, about, what is that? Half an inch for 12 months. So 6 inches down to about 2.75 inches. Growth really slows down. And so with that, the child who just always seemed to be hungry when they were quite young is less interested in food. And so parents can perceive this as a problem with appetite when it's really just normal physiological, that the child is not growing as quickly, their needs are not as high, and so they are less interested in food. Some common nutrition problems you should look for in the toddler. Always screen for adequate intake of high iron foods to look for anemia. We talked about that in growth and development. You can always do the oral exam to look for evidence of dental caries. So are they eating too many sweetened beverages, or are they just not taking good care of the oral cavity? Constipation. Is it caused by, let's say, low muscle tone, a child who has neurological problems, or a child who won't drink or eat fruits and vegetables very well? Are they eating low iron foods and so more susceptible to lead poisoning? Are they food secure? We know poverty rates are higher among children, and food insecurity is higher among children. And then also, is the food in the home safe to eat? Older children, as a reminder, middle childhood is called 5 to 10 years, and then the pre-adolescent is 9 to 11 for girls and 10 to 12 for boys, which can also be called school age. And remember, the school age child is going to have even slower growth than the preschool, but they should still stay on track and plot them. And also remember, when you're looking at school age children, you're also looking, do they have healthy eating habits? Do they eat at least 3 meals a day? Probably children eat too often now, too many snacks, but at least 3 meals a day. Do they have an opportunity to eat? And is the food that they're given the opportunity to eat healthful? Those can help prevent immediate and long-term health problems, but also may be associated with improved academic performance and ability to concentrate. And then in adolescence, puberty begins during early adolescence, where you have this sexual maturation, and with it you'll have this increase in appetite and an increase in height and weight. And what often happens is the child actually kind of begins just eating a lot, and they might get a little bit heavier, and then they have a height growth that really stretches them out. And there's great individual variation in maturation. So if you're looking at some of the age-based formulas for calculating energy needs, if that child is still kind of more in a pre-adolescent stage, it may not make sense to give them the higher needs of a child who is actually aggressively putting on mass. So just some take-home things. Remember that biological, psychosocial, and cognitive changes affect nutritional status, and that rapid growth increases nutrient needs. So if you see a child and they're growing rapidly, that may mean that they need more energy than usual. And also remember that independence may cause adoption of health-compromising eating behaviors. So that actually can occur both in toddler stages, toddler and preschool, and in adolescence. So the toddler or preschooler may go on these eating jags or refuse to eat certain foods or insist on only eating certain foods because they're trying to get independence from the parent. And just in that same way, the adolescent who doesn't want to listen to mom and dad anymore and doesn't want to eat their fruits and veggies and wants to go out to eat all the time may adopt health compromising eating behaviors. Just a reminder of kind of when menarche occurs in females, which is about 2 to 4 years after the development of breast buds, and it ranges from about 9 to 17 years. And also a reminder that young girls who are on restrictive diets, maybe they're around a parent or other kids who are really restrictive, maybe they're in a ballet class, and they start to mimic the other girls, may actually delay or slow their growth or slow the onset of puberty. For males, they really do have a great deal of variation in when sexual maturation occurs for them. And they have longer linear growth. Many males continue to grow past being seniors in high school up till they're about 21. That's basically it. And just a reminder of kind of when those early, middle, and late adolescent periods are. Also remember that adolescent eating behaviors are influenced by peers, but also parental modeling, although peer influences become stronger. Also maybe by mass media, by their body image, and they kind of have all these pressures on their food at a time when they're really they're exceeding their daily energy requirements. And that is all we have to talk about today.